epithalamus. Okay, we'll discuss these three topics in detail. Next slide. So these are the parts of the diencephalon. Okay, so part of the brain. What is diencephalon? It is part of the brain that lies between the cerebral hemisphere and the midbrain. Cavity of the diencephalon is third ventricle. এই তোদেরকে বললাম না সামনে এসে বসতে, উঠে সামনে এসে বস। So the diencephalon consists of pairs of thalamus, hypothalamus and metathalamus. Metathalamus consists of medial geniculate body and lateral geniculate body. Subthalamus and epithalamus. Epithalamus consists of this pineal gland, habenular nuclei and habenular commissure, posterior commissure and stria medullaris thalami. So these are the structures forming the epithalamus. So today we will discuss thalamus. Metathalamus consists of these two structures, medial and lateral geniculate body, and epithalamus consisting of pineal body, habenular nuclei and commissure, posterior commissure and stria medullaris thalami. দাদা এই ফ্যান দুটো চালিয়ে দিন না, ফ্যানটা আর এই সামনের লাইট দুটো বন্ধ করে দিন। Okay, so first we will discuss thalamus. Thalamus is a Greek word. It means the chamber. এই ফ্যানটা খারাপ হয়ে গেছে, ফ্যানটা চালিয়ে দিন। It is a large ovoid mass of grey matter situated on the each side of third ventricle above the midbrain. Okay, so thalamus, this is the location of the thalamus. What is the size? Length is about 4 cm antero-posteriorly. Width and vertical diameter is about 1.5 cm. What is the axis? The long axis of thalamus is oblique and it is directed backward and laterally. So this is the axis of the thalamus. Next is interthalamic adhesion. What is it? You have seen in your viscera. It is a narrow band of grey matter that connects both the thalami across the midline. This interthalamic adhesion. Next. So what are the functions of the thalamus? Functions are very, very important. Functions and nuclei of thalami are important. So function is, it acts as sensory relay station. Thalamus is a sensory station for all impulses except the olfactory sensation. Pain and temperature perception. Thalamus is capable of co-recognition of pain and temperature sensation. Next is extrapyramidal function. It conveys the sensory inputs of cerebellum and basal ganglia to the motor cortex and influences the motor activity. So this is extrapyramidal function. Next is maintenance of wakefulness and alertness through influencing the ascending reticular activating system. Okay, it is lying within the brainstem. Next, emotional behavior and recent memory. It play a role as a part of limbic system in emotional behavior and recent memory mechanism. Autonomic control of viscera. It takes part in autonomic control through the hypothalamus, helps in mood and emotional balance. Personality and intellect of an individual also depends on thalamus. Okay. Next we will discuss external features of the thalamus. Each thalamus has two ends, anterior and posterior end, and 4 surfaces, superior, inferior, medial and lateral surface. So these are the presenting parts. Now we will discuss the individual parts in details. First, the ends. Anterior end, it is narrow and rounded and lies closer to the midline. Form forms the tubercle of thalamus, forms the posterior boundary of interventricular foramen of Monro. You have seen in the viscera the location of the thalamus on the two sides of the third ventricle. Okay, below the caudate nucleus, forming floor of the lateral ventricle. Okay. Posterior end, it is expanded and known as the pulvinar. It overhangs the superior colliculus and its branchium. Next, see here, these are the cavities of the lateral ventricle, and here is the thalamus forming the floor of the lateral ventricle. Okay, these are the thalamus, and this is third ventricle. Thalamus is lying on the two sides of the third ventricle. So this is the location. Next we go to surfaces of the thalamus. First, the superior surface. It is free, convex and covered by a layer of white matter, and its lateral part forms the floor of the lateral ventricle. Its medial part is covered by tela choroidea of the third ventricle that separates it from the body of the fornix. So this is relation of superior surface. Now medial surface, it forms the part of lateral wall of third ventricle covered by ependyma, and it presents the interthalamic adhesion that connects right and left thalami. Okay, so two medial surfaces of the thalami are connected by interthalamic adhesion. Next is inferior surface. It is continuous with subthalamus, and posteriorly it is free and forms the inferior surface of the pulvinar. Next is lateral surface. It is flat, forms the medial boundary of the internal capsule. So these are the four surfaces of the thalamus. Next, see here, this is relation of thalamus with the third ventricle. This area is the third ventricular cavity. See, this is the interthalamic adhesion. These are the two thalami. They are connected by this interthalamic adhesion through the cavity of third ventricle. And see the relation. Here is the anterior end. This is posterior end or pulvinar end. Okay. So this is view from the superior aspect. It is a transverse section through the third ventricle. Okay. Next. And this is a one coronal section. Okay, coronal section through the thalamus. See here, these are the choroid plexus of the lateral ventricle extending into the third ventricle also. Here are the two thalamus lying on two sides of this third ventricle, and thalamus is forming the lateral part of the floor of the lateral ventricle. And lateral to the thalamus, here lies the internal capsule, then the lentiform nucleus, claustrum. Okay, and at the lower end, so here is the upper end. Near the upper end lies this caudate nucleus, and near the lower end, here lies the subthalamus. Okay, understood? Next. So superior surface of thalamus is related to the body of the caudate nucleus laterally. Stria terminalis and thalamostriate veins runs between the thalamus and caudate nucleus. Okay. Choroidal fissure. What is choroidal fissure? It lies between the fornix and the superior surface of thalamus. The tela choroidea of the third ventricle invaginates the lateral ventricle through the choroid fissure. Stria medullaris thalami separate the superior surface from the medial surface of the thalamus. Next is hypothalamic sulcus. You have seen it. It is a groove in the lateral wall of third ventricle, extends from interventricular foramen to aqueduct of Sylvius. It separates hypothalamus from the thalamus. Thalamus above, hypothalamus below. Tinea thalami. What is tinea thalami? It is a line of reflection of ependyma of third ventricle from its lateral wall to its roof. Okay, this is known as tinea thalami. Another is trigonum habenuli. It is a small triangular area between the posterior part of stria medullaris thalami and superior surface of the thalami. Okay, these two are not that much important. Next, see, these are the major efferent connections of thalami, from which part impulses are going to the thalamus. It acts as a relay station for different sensations. So all the sensations are coming from, see, these are the Y-shaped white matter structure. Thalamus is a gray matter. Okay, so white-shaped white matter structure is dividing the thalamus into different nuclei. So here is anterior nuclear, here is lateral dorsal, lateral posterior, pulvinar, ventral anterior, ventrolateral, ventral posteromedial, ventral posterolateral. Okay. So these are the main important nuclei of the thalamus. So these are the afferent connections. Medial dorsal is receiving afferent connection from amygdala, hypothalamus, from reticular formation. Here this pulvinar area, it is getting impulses from superior colliculus and pretectum. Here cerebral cortex, medial lemniscus, spinal lemniscus is going to ventral posterolateral nuclei. Trigeminal lemniscus, solitariothalamic tract going to the ventral posteromedial nuclei. Cerebellum red nucleus connected to ventrolateral nuclei. Globus pallidus to the ventroanterior nuclei. Mammillary body to the anterior nuclei. Okay. So all these are afferent connections of the thalamus. Next we go to efferent connection. From the thalamus, the stimulation is going to which areas? So from mediolateral, it is going to amygdala and hippocampus. From mediodorsal, prefrontal cortex. From here, anterior nucleus and lateral posterior to cingulate gyrus. Here, from here to the corpus striatum. From the pulvinar area into parahippocampal gyrus, parietal occipital temporal lobes. Okay. From VPM and VPL to postcentral gyrus, from ventrolateral to motor area and premotor area, ventroanterior to the premotor area. So these are the efferent connections of the thalamus. Next, see these fibers are showing the afferent and efferent. So here is thalamus, internal capsule, and here is the globus pallidus. So you can see these arrows are showing the ascending tracts. Prerubral field, major ascending tract from dentate nucleus of the cerebellum, from red nucleus, it is coming from globus pallidus. Okay, this blue one and red fiber. So all these are going to the thalamus. And from subthalamic nuclei and globus pallidus, these two are also connected with each other. Next we go to the internal structure of the thalamus. External structure, all those surfaces and two ends that you have seen in your viscera. Now we go to the internal structure. So gray matter of the thalamus, the Y-shaped internal medullary lamina divides the thalamus into anterior, medial and lateral parts. We have seen in previous picture Y-shaped internal medullary lamina. Anterior part lies between the limbs of the Y and medial and lateral part on either side of the stem of the Y. And the gray matter of the thalamus consists of a number of nuclei. The ventral part of thalamus lies inferiorly and dorsal part lies superiorly. Next, thalamus mainly consists of gray matter and a small layer of white matter. So we will discuss the white matter. It contains small quantity of white matter as following thin lamina: stratum jonule on the superior surface, external medullary lamina on the lateral surface, internal medullary lamina lies within the thalamus. Okay, the Y-shaped area. Internal medullary lamina is a vertical sheet of Y-shaped white matter that bifurcate antero-superiorly. Okay, so these are the white matter area. These are very small area. White matter, mainly gray matter is present, and in this area white matter is present. Next we go to the thalamic nuclei. Thalamic nuclei are the nuclei of anterior, medial, lateral, interlaminar and reticular nuclei. Okay, so anterior part it contains the anterior nuclei, medial part contains medial dorsal nuclei. Only one is present in humans. Then lateral part, dorsal tier. Lateral part has this tier of nuclei, ventral tier, dorsal tier, and other nuclei. All these are located in the lateral part. So dorsal tier of nuclei, it contains the lateral dorsal nuclei, lateral posterior nuclei, and pulvinar nuclei. The ventral tier of nuclei, it consists of ventral anterior, ventral lateral, ventral posterior nuclei, ventral posterior lateral, ventral posterior nuclei again divided into two parts, ventral posterior lateral VPL and ventral posterior medial VPM. Okay, these two are important. So some of the important impulses are going to this nuclei. Next, other nuclei are the medial geniculate body, lateral geniculate body, intralaminar nuclei, centromedian nuclei, midline nuclei, and reticular nuclei. So all these are present in the thalamus. These two are mainly included in the metathalamus, medial geniculate body and lateral geniculate body. Next, see the different nuclei. Here, this is Y-shaped internal medullary lamina. Here is the external medullary lamina. Here, interthalamic adhesion has been shown. So, these are the two white matter area, and the nuclei are the gray matter area. See the nuclei anterior to the two limbs of the Y. Here is the anterior nucleus. Now this is medial part and here is the lateral part. So most of the nuclei are located in the lateral part. Medial part contain only one nuclei, medial dorsal nuclei. And within the internal medullary lamina, there are intralaminar nuclei. Within the lateral part, you can see ventral tier, dorsal tier of nuclei. Dorsal tier is containing these three lateral dorsal, lateral posterior, pulvinar. Okay. Ventral tier is consisting of ventral anterior, ventral lateral, ventral posterior. Ventral posterior again two nuclei is present, ventral posterior lateral, ventral posterior medial. Okay. And here is the reticular nuclei, medial to the thalamus, reticular nuclei, and just medial to the external medullary lamina, and posterior to near the posterior end to geniculate body, medial and lateral geniculate body are present. So all these are the nuclei. You have seen the location of different nuclei of the thalamus. To practice a schematic diagram like this, if the nuclei of the thalamus comes as a short note, you have to draw a diagram like this. Next. Okay, so now all these nucleus, where they are getting their afferent impulse and where they are sending their efferent. Okay, so that you have to know, and what are the functions of individual nuclei. First is anterior nuclei. It is getting afferent from mammillary body via the mammillothalamic tract, and efferent is going to cingulate gyrus. Function associate with limbic system. It helps in emotional behavior and recent memory. Next is medial nuclei. It gets afferent from hypothalamus, amygdala, other thalamic nuclei. Efferent is going to prefrontal cortex. It's what are the function? It helps in association and somatic activities and personality of individual mood and feelings. Next we go to lateral dorsal group. Lateral dorsal, lateral posterior and pulvinar. It is getting afferent from superior colliculus, and pretectum. And efferent is going to cingulate gyrus, parahippocampal gyrus, parietal, occipital, temporal lobes. Okay, you have seen in previous picture afferent and efferent connection. From there you can correlate. And what are the function of dorsal group? Forms part of limbic system, helps in sensory analysis by parieto-occipito-temporo association cortex. Okay. Next is BPM, ventral posteromedial, trigeminal lemniscus, and solitariothalamic tract. Solitariothalamic tract is coming from nucleus tractus solitarius. Okay, NTS. So from there it is getting its afferent. Efferent is going to post central gyrus, and function is relay station for those sensation coming from here. Next is ventral posterolateral nucleus, VPL. Afferent is coming from medial lemniscus, spinal lemniscus. Efferent is going to the post-central gyrus. And functions are relay station for pain, temperature, touch, proprioceptive sensation from whole body except the face and head. Okay. Next is ventral anterior nuclei. Afferent coming from globus pallidus through the subthalamic fasciculus. Efferent is going to premotor area. Function is relay station for striatal impulses, and they modify the motor activity. Next is ventral lateral nucleus. Afferent coming from cerebellum via dentadothalamic tract, and from red nucleus via rubprothalamic tract. Efferent is going to motor and premotor areas, and relay station for cerebellar impulses and influences the motor activity. So these are the different afferent and efferent connections of thalamus can also come. It is hard to remember. You have to revise multiple times. Okay. Next, you practice those diagrams. That's how you can remember. Next is intralaminar nuclei. It has centromedian and parafascicular nuclei. Afferent coming from reticular formation. Efferent is going to other thalamic nuclei and corpus striatum. Function, it helps in general awareness of painful stimuli, sensory motor integration, maintenance of arousal. Next is midline nuclei. Afferent coming from reticular formation. Efferent is going to hippocampus and amygdala. And function is, it forms a part of limbic system, memory and arousal responses. Next is thalamic reticular nucleus, lies between external medullary lamina and internal capsule. Afferent coming from corticothalamic fibers. Efferent is going to other nuclei of thalamus and thalamocortical fibers. Function helps in regulation of interthalamic activity. Next. Okay, so the location has been written. Anterior thalamic nuclei are endorsed by bifurcation of Y-shaped internal medullary lamina. Okay, in between the two limb of the Y. Medial thalamic nuclei lie medial to the internal medullary lamina, and it consists only of dorsomedial nuclei in human. Lateral thalamic nuclei lie lateral to the internal medullary lamina, and they are divided into two groups: dorsal tier, ventral tier. Dorsal tier consists of lateral dorsal, lateral posterior, pulvinar. Ventral tier consists of ventral anterior, ventral lateral, ventral posterior. Ventral posterior again divided into VPL, VPM. Next is ventral anterior, lies in the anterior pole of ventral group in between the external and internal medullary lamina, and it extends anteriorly from the reticular nucleus to the ventral lateral nucleus posteriorly. So these are the location of different nuclei. Next, see here, this is thalamus. Okay, interthalamic adhesion, and here this medial to the thalamus lies the third ventricular cavity. Next, ventrolateral nucleus lies between ventral anterior and ventral posterior nuclei, and it lies between the lateral dorsal, superior and subthalamus inferiorly. Ventral posterior nucleus, it lies between the ventral lateral and ventral anterior to the pulvinar. Lies inferior to the lateral posterior, and the ventral posterior nucleus is divided into VPM and VPL. Next is medial geniculate body. It is rounded elevation situated posterior on the inferior surface of thalamus, separated from pulvinar by the superior brachium. Next is lateral geniculate body, is a small ovoid projection on the inferolateral aspect of pulvinar, and it lies lateral and anterior to the medial geniculate body. So these are the location of different nuclei. Next, lateral dorsal. All these you have seen in the picture. Next. Okay, next. Okay, blood supply is important. So arterial supply, it is supplied by branch of the posterior communicating posterior cerebral and posterior choroidal arteries. Venous drainage is via thalamostriate veins and choroid veins of the third ventricle, and these veins unite to form the internal cerebral vein. Okay, so this is blood supply of the thalamus. Next clinical aspect, thalamic syndrome. Thalamic vascular lesion of the thalamo-geniculate branch of posterior cerebral artery results in thalamic syndrome. It is characterized by these features: hyperesthesia, exaggerated sensation. It is a relay station, so there will be exaggerated sensation. Severe spontaneous pain on the opposite side of the body. Emotional instability, that is, patient may laugh or cry without any reason. Thalamic phantom limb, that is, patient is unable to locate the limb and the eyes, if the eye is closed, and develops the illusion that the limb is lost. Okay, so this is thalamic phantom limb. Then thalamic hand, it may occur in thalamic lesions. Opposite hand is involved. The forearm is pronated, wrist flexed, metacarpophalangeal joint is flexed, and interphalangeal joint is extended. Okay, so all these are the signs and symptoms of the thalamic syndrome. Next is thalamic pain syndrome or Jarin-Rossi syndrome. It involves loss of sensation followed by progressive agonizing pain in the parts of body where the loss of sensation has occurred. Thalamic syndrome shows allodynia, a painful sensation elicited from an innocuous stimuli on normal skin. Hyperpathia, an unusual and intense response to nociceptive stimuli, and dysesthesia, abnormal sensation triggered by sense of touch. Okay, it is a relay station mainly, so for all the senses. So all the senses will be abnormal if lesion occur in the thalamus, and it will occur in the opposite side because opposite side fibers are coming to the, there is a crisscross. Okay, before entering into the thalamus. Next we go to the, so we have completed thalamus. You have to know the functions, nuclei, their afferent efferent connections, okay, and practice a schematic diagram. And this clinical aspect, if you can remember, it's good. Okay. So next is metathalamus. Function and nuclei are very, very important for thalamus. Metathalamus consists of medial geniculate body and lateral geniculate body. Medial geniculate body, it is a oval elevation on the inferior aspect of the pulvinar of thalamus and lateral to the superior colliculus. Here is the medial geniculate body. See, these are superior colliculus, inferior colliculus. Here is the pulvinar end of the thalamus. So it is medial geniculate body is elevation on inferior aspect of the pulvinar. You can see the location, inferior aspect of pulvinar of thalamus and lateral to the superior colliculus. It is connected with inferior colliculus by the inferior brachium. Here, it is connected by the inferior brachium to the inferior colliculus. The cells of medial geniculate body are arranged in knee-shaped profile, hence called geniculate. Genu means knee, that's why the name is given geniculate. Next, what are the connections? It gets its afferent connection from inferior colliculi through the inferior brachium and some direct fibers from the lateral lemniscus. And efferent is going to auditory radiation to the auditory area of the temporal lobe. That is auditory area, you have seen Brodmann's area 41 and 42. Okay, in the superior surface of temporal gyrus, superior temporal gyrus. Function, it acts as relay station in the auditory pathway. Okay, that you have to remember. So, medial geniculate body acts as a relay station for auditory pathway. Next we go to lateral geniculate body. Lateral geniculate body, it is an oval prominence at the posterior end of the optic tract. Lies on the inferolateral aspect of pulvinar, you have seen in previous picture, just lateral to the medial geniculate body. It is located and anterolateral to the medial geniculate body. Structure, neurons are arranged in 6 layers separated by nerve fibers. Here you can see the 6, 1, 2, 3, 4, 5, 6. And the layers are numbered as layer 1 to 6 from ventral to dorsal. Here, ventral to dorsal. The layer 1, 4 and 6 receive fibers from nasal side of retina of the opposite side, crossed fibers here. From the opposite side, 1, 4 and 6 is getting crossed fibers. And the layer 2, 3 and 5 receive fibers from temporal side of the retina of the same side. Okay, 2, 3 and 5 getting temporal side of retina, same side, uncrossed fibers. There is crossing of some fibers in the optic chiasma, that's why this is occurring. Next, connections. Afferent is coming from optic tract, efferent is going from optic radiation that passes through retrolenticular part of internal capsule to the visual cortex. Visual cortex is Brodmann's area 17, 18 and 19. Now what are the functions? It is relay station on the visual pathway, and clinical integration. Lesion of lateral geniculate body will lead to contralateral homonymous hemianopia. Okay. Next we go to the epithalamus. So metathalamus we have completed. Next we are going to epithalamus. Epithalamus consists of pineal body or pineal gland, habenular nucleus and habenular commissure and posterior commissure. See here in this picture, here is the pineal gland. Okay, these are forming the posterior boundary of the third ventricle. Here is pineal gland. It has two stalks, superior lamina of the stalk and inferior lamina of the stalk. Within the superior lamina lies this habenular commissure. Within the inferior lamina lies this posterior commissure. Okay. Next. So first we will discuss the pineal glands or epiphysis cerebri. This comes as a short note. Pineal gland or also epithalamus can come as a short note. Most commonly this pineal gland comes as a short note. As it is a small conical projection between the two superior colliculus of the midbrain here. So these are the superior colliculus. In between the two superior colliculus, it is a projecting structure, pineal gland. Lies below the splenium of the corpus callosum. This is splenium of corpus callosum, so it is lying below the splenium of corpus callosum. Weight is about 100 to 200 milligram. What is the shape? Shape is flat, pine cone shaped. Hence the name is given pineal gland. Okay, pine cone shaped. That's why name is given pineal gland. Next, pineal gland has a stalk that divides into two lamina. Inferior lamina is continuous with posterior commissure. Here is the inferior lamina continuous with posterior commissure. Superior lamina is continuous with habenular commissure. Here is the habenular commissure. Next, the pineal recess. It is extension of cavity of third ventricle between the two lamina of pineal gland. Here, you have seen the during the third ventricle, pineal recess, extension of third ventricle. Next is nervous conuri. They are postganglionic sympathetic fibers from the superior cervical sympathetic ganglion that supply the pineal gland. This is known as nervous conuri. Next, the structures. What are the cells forming the pineal gland? It consists of pinealocytes and interstitial cells. Pinealocytes are chief cells of pineal gland, secrete melatonin hormone. Okay. Interstitial cells, they are few cells, support the pinealocytes, and there is corpora arianacea or brain sand. Characteristic feature of pineal gland, these are calcified concretions or deposit that increase with age. Okay, there is calcification in some adults near the pineal gland. You can see as a white dot in your CT scan plate or MRI. Okay. Next, what are the functions of the pineal gland? It helps in secretion of melatonin that inhibits the secretion of gonadotropin from the hypothalamus. Okay. Maintenance of circadian rhythm, that is biological cycle. Next, and it is said pineal gland is considered as third eye. Okay, it helps in our sleep awake cycle. The melatonin hormone helps in sleep awake cycle. Next, we go to the habenular nuclei and habenular commissure. Habenular trigon. Habenular, it means little rain in Latin. It is a small depressed triangular area bounded superiorly by the striamedullaris thalami and superior lamina of the pineal stalk. Okay, near the superior lamina, habenular nuclei is located, and inferiorly by the superior colliculus of the midbrain and laterally by the pulvinar thalamus. Next, so habenular nucleus lies in the habenular triangle, a part of the limbic system. Okay, it is located mainly within the substance of the brain. From the outside, you cannot see the nuclei. Next, habenular commissure. Fibers that connect the habenular nucleus of two sides across the midline lies in the superior lamina of the pituitary stalk. That is forming the commissure. Commissural fibers are connecting two hemispheres. So habenular commissure is connecting two habenular nuclei of the two hemispheres. What are the functions? It forms a part of limbic system and responsible for primitive visceral response to the basic emotional drives. Okay, so you can see in this diagram, this it is getting afferents from hypothalamus, basal nuclei of Maynard, septal nuclei via the striamedullaris thalami, from the globus pallidus also, and these are the efferent going to the interpeduncular nuclei. Okay, and going to reticular formation and different autonomic centers. Next, we go to the posterior commissure. This is bundle of fibers that cross the midline in the inferior lamina of pineal stalk. Here is the posterior commissure lying in the inferior lamina of pineal stalk. Contains fibers from medial longitudinal bundle of interstitial nuclei and many other adjacent areas. Exact function is not known. Okay. Next. Okay, that's all. So all these structures are forming the epithalamus, pineal gland, habenular nuclei and habenular commissure, and the posterior commissure. Okay, so epithalamus can come as a short note, or individually pineal gland can come as a short note. Metathalamus is also important for your short note. You have to write the two geniculate bodies, medial and lateral geniculate bodies. And for thalamus, to prepare very carefully the thalamic functions and thalamic nuclei and their connections, afferent efferent connections. So these are important for your theory question. Okay, that's all. Any queries?
All parameters in your previous reports. Okay, and this conjugation bilirubin is normal, and bile salt is negative, and bile pigment is nil in the urine. Okay, urobilinogen is already positive. Now there is unconjugated means indirect. Indirect bilirubin is high and total bilirubin is high due to indirect. So this is the clear case of hemolytic jaundice. Hemolytic jaundice. Perihepatic jaundice is a class of enzymes, and if you are going more specify of this jaundice, then you mention it is hemolytic jaundice. What will you see in hemolytic jaundice? Yes, destructions of RBCs, the level of the hemoglobin. The level of the hemoglobin. Okay. Now you tell me the symptoms of jaundice. 1 minute. Pale yellow color of skin and sclera. Second, brown color of stool. Urine, dark color of urine. Okay. Or lethargy. Lethargy or melasma और कोई symptoms, weight loss हो सकता है, weight loss हो, but it is not a symptoms of hemolytic jaundice. Okay. So all of these things about pre-hepatic or hemolytic jaundice. Now, in another case, we discuss another case. Why it is called icterus? ICTERUS. Icterus. The normal level of the total bilirubin 9.8 milligram percentage, conjugated is 5.3 milligram percentage, it is 4.5 milligram percentage, serum alkaline phosphatase is 18 Ka units per dl, SGOT is 310 units per liter, and SGPT is 240 units per liter, and these are positive. Now you mention the case. Again, this is another class of enzymes and you easily give the answer. You easily give the answer. सोचो बताओ. Hepatic jaundice. Very good. You give the right answer. But how will you justify it? Very good. Why it is value is high? You are going to the level. You give the exact answer because these are transaminases. These are present in hepatocytes. If there is destruction of hepatocytes, what happens? These enzymes become drawn on the liver. Okay, these enzymes drawing on the liver. On the basis of hormone action, it is 3 types. Can you tell me? Hormone is 3 types. On the basis of hormone action. कुछ स्किप कर रहा है दिमाग से. एक तो टारगेटिंग ऑर्गन पे जाके करता है. I will skip something. But SGOT, SGPT, if it is present in the hepatocyte, if there is destruction of hepatocytes, this comes in the blood and the level of this SGOT, SGPT is high. Now you will see what happened. Both the level, conjugated and unconjugated, are increases. Why? Simply what happened? Bilirubin is formed here, which you called unconjugated. Okay, it is combined with albumin. It is combined with albumin, then it comes to the liver. Then these liver not conjugated this bilirubin. Not conjugate this bilirubin because liver is not functioning well. So the level of unconjugated bilirubin is high because it is not further metabolized. And some of the conjugated bilirubin is not properly drained out from this liver. So what happened? Both unconjugated and conjugated bilirubin become increases. You will see the report. So this is the clear case of hepatic jaundice. So now question is asking how the hepatic jaundice is happening. What is the reason? Either hepatitis, fatty liver, ALD, acute liver disease, chronic liver disease, CLD, liver cirrhosis. Okay, all these are, वो तो अलग अलग हो गया, non-alcoholic fatty liver disease, NFLD or other things. You mention it, but it is a clear case of hepatic jaundice. Okay, समझ में आया आप पे? तीनों हमने डिस्कस किए हैं. We discuss all the 3 things. Now I can change a case. Now case is what? Now case is a 3-day-old baby comes in pedia OPD with chief complaint of high pitch crying. Loss of appetite. Loss of appetite in the children, it is a clear symptoms of less feeding of milk. Less feeding of milk. Okay, and dark stool okay, with these laboratory findings. There is serum bilirubin total is 20 milligram percentage. Okay, the unconjugated or indirect, there is, firstly we calculate direct is 0.8 milligram percentage and indirect is 19.2 milligram percentage. Okay, OTPT are both normal. OTPTR, it is being normal. Okay. Now you will justify the case. हाँ क्या चल रहा है दिमाग में, क्या चल रहा है? हाँ, very good. Not periphery, it is neonatal jaundice. Very right answer, neonatal jaundice. Actually, if something cases comes in your exam, firstly you see the child age. It is 3 days. It is happening between 24 hours to 72 hours. 3 dose baby with high bilirubin level. It is a clear case of neonatal oblique physiological jaundice. Physiological jaundice. Why? Because the liver of such child is not properly developed. They are not accepting bilirubin to conjugate. That's why the level of bilirubin become high. Understand? That's why the level of bilirubin become high, and due to this, this is not metabolize the bilirubin, and this such kind of children are suffer from neonatal jaundice or physiological jaundice. And the case is high pitch crying. High pitch crying is it is regularly cry due to abdominal pain. You understand? The indirect bilirubin is toxic in nature. It is toxic. It creates pain, abdominal cramps. Okay, but if liver is properly working, it is conjugated, then it is not toxic. Okay, less of feeding, and this is the clear case of physiological jaundice. I think all of you understand all these charts. If this chart comes in your exam, you easily give the answer. ठीक है, लो फोटो ले लो, किसी को लेना है इस चार्ट्स के तो important. Okay, and these case report we discuss are in the form of charts. During your final Viva exam, the external examiner give you the chart. Just simply take this chart, you read this chart, and on the basis of your reading, on the basis of your laboratory findings, you have to confirm preliminary diagnosis and also mention the biochemical basis of this case. How will you confirm that this having such disease? Okay, now first case you write, I will mention in the board. Okay, then we discuss. Laboratory reports of blood and urine in jaundice. We mentioned the disease also. Jaundice patient were as follows. Jaundice patient were as follows. Okay, were as follows. The first one is serum bilirubin total. Yes, total. Okay, serum bilirubin total. The value is 6.6 mg percentage. Then 6.6 mg percentage. Then conjugated is 14.8 milligram percentage. Okay, and unconjugated is 1.8 milligram percentage. This is serum alkaline phosphatase, serum ALP, alkaline phosphatase, that is 100 Ka units per dl. Okay, then SgOT is 35 unit per liter, or either international unit per liter, whether both the units are same, and SgPt, okay, that is 35 units per international unit per liter. Okay, the normal range of this is 5 to 20 international unit per liter, and this is 10 to 35 international unit per liter, and this is 3 to 13 Ka units per dl. Okay, actually एक मिनट में हाँ K units per dl. Okay, actually these case report, this case chart is given to you, and you will identify it which is the disease. So don't try to give the answer very fastly. ऐसा नहीं है केस मिला तुरंत आंसर दे दिया, नहीं. Think before you speak. Think before you speak. What you concluded? I will ask one by one. Okay? Yes. Who can give the answer of this question? Laboratory reports of blood and urine. Okay, sorry. There is urine is also given reports. Bile salt. Don't talk. Positive. Bile pigment. Positive. And urobilinogen is negative. Now tell me the answer first. It is a clearly patient of jaundice because the serum bilirubin level is high. The normal level of serum bilirubin is 0.2 to 1.2 mg per dl. Okay, and conjugated means direct bilirubin, unconjugated means indirect bilirubin. Okay, so this is, if you see the report of these bilirubin label, you easily give the answer. You easily give the answer. Okay, there is conjugated level is 14.8 milligram percentage. Okay, and unconjugated is 1.8 milligram percentage. Means there is something problem in the hepatocytes. Okay, this is clearly a case of hepatic jaundice. This is clearly a case of hepatic jaundice. Okay. Sorry. It is not a clearly case of hepatic jaundice. It is a simple case of obstructive jaundice. Obstructive jaundice. It is called post-hepatic. Don't talk. Don't discuss here. If you want to give the answer, just stand up and discuss here. It is post-hepatic jaundice. Because serum alkaline phosphatase level is also high. Serum alkaline phosphatase is also high. This level is become, if we take in international unit per liter, then this is normal level is 145 international unit per liter. And it is more than that because it is in King Angstroms. It is up to 300 unit per liter. This is the range of this particular alkaline phosphatase. Okay. So what is? It is a case of obstructive jaundice. Okay. Now, if I will ask you, how will you say that this is obstructive jaundice? Anybody can tell? अभी क्लियर हो जाएगा. देखना थोड़ा, इसको मैं हटा देता हूं यहां से. इतना मैंने हटा दिया. ठीक है. अभी देखो, ये क्या है आपका? These all are RBC. red blood cell, and from this can break down into two things. The first one is heme plus globin, and this is again break down into biliverdin, okay, by heme oxygenase activity. Heme oxygenase activity, it is converted into biliverdin, and then by enzyme biliverdin reductase. By enzyme biliverdin reductase, this is now converted into bilirubin. Okay, bilirubin. This we call here as what? Indirect or unconjugated. Unconjugated bilirubin. Somebody's examiner asked the question, how will you say what is the meaning of indirect, what is the meaning of unconjugated? You clearly say bilirubin alone. It is not combined with other things. Okay. And sometimes student give the answer that bilirubin, if I will talk, it is direct bilirubin, they say bilirubin combined with the albumin. It is wrong. It is wrong, because anything else in our body which are not movable alone, then it's combined with the protein for transport. Okay? Understand? You easily understand all these things. Okay? Now it is combined with albumin, then these complex now going to the next stage. We call this stage, this is our bile duct. Okay, and here there is a process called conjugation occur. Okay, and basically bilirubin is come and protein is left out. Albumin protein is left out because it can combine with the receptors. These receptor may be present. It can combine with the receptor, and here bilirubin combined with UDP glucuronate. Okay, UDP glucuronate enzymes, and it is called conjugated bilirubin. What is called? Conjugated bilirubin. Now this conjugated bilirubin is again transported from this bile duct, and from this bile duct it going to further in the next step. For further process, because it is a cyclic process. Bilirubin metabolism is generally occur in the liver. Okay, it is going to the kidney, where it is either going converted into urobilinogen, and urobilinogen, you already know, it is responsible for coloration of urine because it is a urochrome. Okay, and it is going to straccobilinogen by bacterial activity, and it forms straccobilinogen. Straccobilinogen is basically responsible for coloration of stool. Okay, now what is happening here? The SGOT and SGPT. What is SGOT and SGPT? SGOT and SGPT are transaminases. Transaminase what? It is the enzymes present in the hepatocytes. Okay, these are the liver, these are the hepatocytes. Okay, where SGOT and SGPT are normal in the case. SGOT and SGPT are what? It is 35-35. It is normal. Okay, but due to obstruction, there is no passage of any kind of direct bilirubin. That's why the direct bilirubin level is high, because its direct bilirubin is making in the hepatocyte. It is not passes through it. And there is indirect bilirubin is also level high, because normal level of bilirubin is what? It is 0.2 to 1.2 mg per dl, and direct is 0.2 to 0.5, and indirect is 0.2 to 0.1. Sorry, it is 1 mg per dl. So these are the ranges of this bilirubin. In this case, both bilirubin, direct, indirect, is both increases, but direct increases in high amount. That means the conjugation is happening here, but it is not properly passed from the liver because there is obstruction in the bile duct, and due to this, the LPAL alkaline phosphatase level is also high. Okay. Now, in urine report, what will you see? The bile salt is positive in the urine, bile pigment is positive in the urine. It is clearly mentioned that. How can you identify bile salt in urine? By which test? You tell. Just a minute. Tell me the name of the test. कौन सा? Speak loudly. Hay sulfur test. Bile pigment Faucet test. If both the tests are positive, you clearly mention it is a case of obstructive jaundice. Okay, so this is a obstructive jaundice. By seeing of the report, you easily understand that. By seeing only the report, you easily understand that both the bilirubin level is increases here. So there is no passage of bilirubin totally from the liver, and there is accumulate in the blood. Due to this getting positive results. Okay. Now what happened in prehepatic? Prehepatic. Now in the second case. Now in the second case, में क्या है? See the case and give the answer. First is serum bilirubin total, that is 12.6 mg percentage. कोई बात मत करो, ये आवाज नहीं आनी चाहिए कान तक. Conjugated bilirubin is 0.6 mg percentage and unconjugated is 12.0 milligram percentage. Serum ALP, alkaline phosphatase, is 9 Ka units per dl. ठीक है? And OTPT, SGOT, SGPT. What is the full form of SGOT and SGPT? Very good. SGPT, transaminases. Transaminases is a special class of enzymes. What is the function of these transaminases enzymes? Transfer of amino groups. Okay. And this is our blood reports. And in urine reports, bile salt, don't talk, nil. Bile pigment, nil. Urobilin is positive. Now tell me the case. Now you will tell me the प्रोबेबल डायग्नोसिस. एक बंद कर दो ये लाइट जरा, एक लाइट बंद कर दो. कोई नहीं, ये वाली नहीं दिख रहा है यहाँ पे. सब ये वाला ऑफ करते हैं. ठीक, अरे नहीं, ठीक है. ओके, सो दिस इज द केस. नाउ यू विल टेल मी.
Fourth ventricle is the tent-like cavity of the hindbrain. Hindbrain is brachiocephalon. It is lined by ependyma and it contains the cerebrospinal fluid, CSF. Okay. What is the location of fourth ventricle? It lies between the cerebellum behind and the pons and upper part of medulla anteriorly. Okay, so this is the location of fourth ventricle. Now the continuity. Continuity superiorly, the fourth ventricle continues with the cerebral aqueduct of the midbrain, and inferiorly, the fourth ventricle, silence everyone. কতবার বলা হচ্ছে? Okay, so continuity of the fourth ventricle. The fourth ventricle continues with the cerebral aqueduct of the midbrain, and inferiorly the fourth ventricle continues with the central canal of closed part of the medulla oblongata. So this is continuity superiorly and inferiorly. Next we go to the boundaries. There are lateral boundaries, roof, floor, and 4 angles: superior, inferior, and 2 lateral angles. So these are the boundaries. We will discuss individual boundaries. First, the lateral boundaries. The fourth ventricle has these following boundaries on each side. Inferolateral boundary is formed by fourth ventricle. First, the lateral boundaries. The fourth ventricle has these structures. Inferolateral boundary is formed by gracile and cuneate tubercles and inferior cerebellar peduncles. Superolateral boundary is formed by the superior cerebellar peduncles. Now the roof and posterior wall. Roof of the fourth ventricle is tail sepate, that is diamond sepate. It has upper and lower parts and an apex. Apex of the roof is directed posteriorly. It is tail sepate, we have learned. So apex is directed posteriorly, okay, and it is entering into the cerebellum. Superior cerebellar peduncles, one on each side. Superior medullary velum in between the peduncles, and lower sloping part of the roof, it is formed by inferior medullary velum and ependyma of the ventricle and fold of pyometer. So these are the structures forming the roof. It has an upper sloping part and lower sloping part. Dutote one velum is present, superiorly superior medullary velum, inferiorly inferior medullary velum. Okay, understood? Next, going to angles of the fourth ventricle. Cavity of the ventricle has 4 angles. Superior angle, at the superior angle, the fourth ventricle continues with the cerebral aqueduct. Inferior angle, at the inferior angle, the fourth ventricle is continuous with the central canal of the medulla oblongata, inferior angle. And 2 lateral angles on each side. The fourth ventricle extends laterally as the lateral recess of the fourth ventricle. Okay. In the third ventricle, you have learned multiple recesses are present, mainly 4 recesses. Here also we will see 5 recesses. Okay. So see here, this part is midbrain, pons, and medulla. Here is the cerebellum, and this tent-like cavity is the fourth ventricle. It is connected above via the cerebral aqueduct with the third ventricle, connected below with the central canal of the medulla oblongata here. Okay. So this tent-like, this is forming the roof. Here is superior medullary velum, here is inferior medullary velum, and this is the median dorsal recess extending into the cerebellum. And you can see the location of the fourth ventricle. It is lying posterior to the lower part of the pons and upper part of the medulla, and anterior to the cerebellum. Okay. Okay. So next part we will go. So location, cavity of hindbrain lies between cerebellum behind, pons and medulla anteriorly. Continuity, superiorly continuous with cerebral aqueduct, inferiorly central canal of the medulla. Lateral boundaries, inferolateral boundary by gracile cuneate tubercles and inferior cerebellar peduncles. Superolateral boundary by the superior cerebellar peduncles. Next is roof. Roof is tail sepate. Upper part is formed by superior medullary velum. Inferior part is formed by inferior medullary velum and ependyma and fold of pyometer. So these are the boundaries. Next we go to communications with the third ventricle via cerebral aqueduct and with the central canal of medulla by a foramen of Magendie, and there is also presence of two foramen of Lasker. Okay, three foramens are present here. Now the recesses, two lateral recesses, two dorsolateral recesses, one median dorsal recess. So these are the recesses of the fourth ventricle. See here, here is the median dorsal recess which is extending into the cerebellum. Okay, this is cerebellum. See the different parts of cerebellum lying in relation with fourth ventricle. Above there is lingula, okay, and below there is nodule. পাশনি এপ্রন ঠিক আছে ঢোক okay so and this blue lining is the ependymal lining and here in the lower part there is one important cistern is present okay cerebellomedullary cistern this also contains the CSF okay and in the lower part it is continuous with central canal of the medulla oblongata next you see here this is the roof has been shown see these are the parts of the cerebellum above there is lingula below there is nodule here this one is the superior medullary velum and below here is the inferior medullary velum and these are the three apertures you can see midline aperture is single aperture foramen of Magendie on the two sides foramen of Lasker okay and lateral recesses are present on these two sides near the opening of the foramen of Lasker okay and this is superior cerebellar peduncles forming the superolateral boundary and inferolateral boundary is formed by the inferior cerebellar peduncles like okay it is a vertical ridge extending on the outer or posterior surface of superior medullary velum in the midline. The trochlear nerve emerges on either side of this ridge. And inferior medullary velum, it is thin and semilunar. It is a white matter. Inferior medullary velum, it is thin and semilunar. It is white matter extending on each side of nodule of vermis of the cerebellum. Its inner surface is covered by ependyma and outer surface by folds of pia matter. Laterally, it is continuous with the white matter of the cerebellum. These are inferior medullary velum. You have seen in the previous picture. Superior medullary velum. Here, pink one is the inferior medullary velum. Velum is a curtain-like structure forming the roof. Next is tinea of the fourth ventricle. These are two narrow bands of white matter, one on each side, that are the downward extension from the inferior medullary velum, and it completes the lower part of the roof of fourth ventricle. Here, in this region, below this inferior medullary velum will be the tinea. We will see next picture. See here, this is the tinea. Okay. Next, we will discuss the floor of the fourth ventricle. Floor of the fourth ventricle very important. It is also known as rhomboid fossa. It comes as a short note or long question. You practice the schematic diagram. This diagram, okay, and the structures forming the floor of the fourth ventricle. It comes as a short note, also a long question. Very important. Floor of fourth ventricle. So, in the midline, you can see there is median sulcus. Okay, parallel to the median sulcus, on the two sides there are two longitudinal sulcus. These are known as sulcus limitans. Okay, and the area between the median sulcus and sulcus limitans is the here is the sulcus limitans and here is the median sulcus. Okay, and these rounded areas, these are forming one elevations in the upper part. These are the facial follicles. Deep to these facial follicles lies the abducens nucleus, that is sixth nerve nucleus, surrounding which lies the fibers of the seventh nerve or facial nerve. Okay, internal genu is present over this area, over this facial follicles, and in the upper part of the sulcus limitans here is a triangular area known as the superior fovea, and here one blackened discoloration you can see, that is known as locus ceruleus. Okay, and in the lower part of sulcus limitans also there is one triangular area that is known as inferior fovea. Here inferior fovea has been shown, and below the inferior fovea the sulcus limitans extends downward and lateral medially up to the median sulcus. Okay, and dividing and below it lies the two triangles, hypoglossal triangle superolaterally and inferomedially is the vagal triangle. And lower end, this lower end is looking like nape of a pen. This area is known as area postrema and below it lies the obex. Okay, understood? And below here, this part is the medulla. You can see here is the gracile tubercle medially, cuneate tubercle laterally. Okay, so these are forming inferolateral boundary of the floor, and superolateral boundary of the floor is formed by the which is superior cerebellar peduncles. These are sections of middle cerebellar peduncle, and inferolateral boundary is partly formed by the inferior cerebellar peduncles. Okay, understood? And in the midline, there are some stria. These stria are known as stria medullaris. And in the deeper plane, in this hypoglossal triangle lies the hypoglossal nerve nuclei, and in the vagal triangle lies the vagal nerve nuclei. Okay, so these are the important structures of the floor. And here one thin membrane-like structure is present at the upper end, that is known as frenulum veli. Okay, and these are the location of trochlear nerve. Trochlear nerve comes out on the dorsal aspect. This is lying on the dorsal aspect of pons and medulla. So trochlear nerve will also pierce the structure of the roof, that is superior medullary filum is also pierced by this trochlear nerve. Then it is winding round the pons and winding down the midbrain mainly at the junction of midbrain and pons, and it going to the anterior side. So these are the important structures of the floor of the fourth ventricle. Okay, so the floor of the fourth ventricle, it is diamond shaped, hence called rhomboid fossa. Why it is rhomboid fossa? Because it is diamond shaped. Okay, it is formed by the posterior surface of pons and an open part of the medulla oblongata. Features: the floor of the fourth ventricle shows these features. One is median sulcus. It divides the floor or rhomboid fossa into two equal halves lying in the midline. Median eminence. It is a longitudinal elevation on either side of the median sulcus. Next is sulcus limitans. It is a shallow sulcus that limits the median eminence laterally. Next is superior fovea. It is a small triangular depression at the upper end of sulcus limitans. Inferior fovea, small triangular depression at the inferior end of the sulcus limitans. Next is facial folliculus. This is very frequently asked. You have to show the facial folliculus. Or in HIPAA, what is, you can be asked what is facial folliculus, how it is formed, like this. Okay. It is oval swelling on the upper part of median eminence at the level of superior fovea, and it is produced by looping fibers of seventh cranial nerve around the abducent nucleus, that is internal genu of the facial nerve. We have discussed it. Next is locus ceruleus. It is a bluish grey area in the upper part of superior fovea, and its color is due to melanin containing cells of substantia ferruginea. In the lower part, the sulcus limitans run obliquely towards the median sulcus, divides the median eminence into hypoglossal and vagal triangles. Hypoglossal triangle, it is a triangular area in the lower part of the floor, and the hypoglossal nucleus and nucleus intercalatus lie deep to the hypoglossal triangle. You have seen in the picture. And vagal triangle, it is a dark triangular area on the median eminence that lies inferolateral to the hypoglossal triangle. Dorsal nucleus of vagus lie deep to the vagal triangle. Next is funicular separations. It is a narrow ridge-like elevation of ependyma in the lower part of vagal triangle. Next is area postrema. It is a small tongue-shaped area between the funicular separations above and gracile tubercle below, and it contains highly vascular neuroglial cells which act as chemoreceptors, and it induces vomiting in response to the presence of emetic substance in the brain, blood. Okay, so that's why it is important. Area postrema, it is induces vomiting in response to presence of emetic substance in the blood. Next is tinea. Tinea is a wide, narrow ridge along the inferolateral margins of fourth ventricle. Next is ovex. It is meeting point of two tinea at the inferior angle of the fourth ventricle. Okay. So, floor of the fourth ventricle, also known as rhomboid fossa. These are the important sulci and depressions. Median sulcus, lateral to the medial sulcus is median eminence. Lateral to it lies the sulcus limitans. At the upper end of sulcus limitans, superior fovea. Lower end of sulcus limitans, inferior fovea. Areas of structures, facial colliculus, rounded structure in the upper part of the median eminence near the superior fovea. Locus ceruleus near the at the upper end of the superior fovea. Hypoglossal triangle near the lower end. Vagal triangle. Then funicular separates. Okay, at the upper end. Area postrema at the lower end. Tinea at lining the inferolateral boundary. Obex is the lowermost end. Okay. Now, clinical integration, blockage of fourth ventricle will lead to hydrocephalus. Any of the ventricle blockage occurs, there will be hydrocephalus. And medulloblastoma, vital centers. Vital centers are present in the pons and medulla. That's why in case of hydrocephalus, there is impairment of vital function. Respiratory center is present in the medulla. Medulloblastoma is the tumor which is blocking the CSF flow. Okay. So these elevated areas are known as the median eminence. In the upper part of median eminence at the level of superior fovea, these are the facial colliculus. Okay, so all these structures you have seen. Diagram, see the structures. Diamond shaped structure, superomedial lateral boundary is formed by the superior cerebellar peduncle. Here is the middle cerebellar peduncle, inferior cerebellar peduncle. Okay, midline there is median sulcus. Lateral to it is the medial eminence. These are the facial colliculi. Lateral to the medial eminence, here is the locus. Here in the superior fovea, near the superior fovea, the bluish colored one is the locus ceruleus. Okay. And in the lower part, here is hypoglossal triangle. Here is the vagal triangle. These are the stria medullaris. Here is the tinea. In this area, here is the area postrema. Here is the obex. Okay, so these are the important. And here in the uppermost end, there is frenulum veli. Okay, and this sulcus limitans, it is the lateral boundary of the median eminence. So obex denotes the inferior angle of the fourth ventricle. Calamus scriptorius, this is asked in your viva. What are these structures? Calamus scriptorius, that means knee of a pain. Okay, the lower part of fourth ventricle resembles the pain knee, hence called the Calamus scriptorius. Stria medullaris of fourth ventricle. Actions of the arcuate nucleus pass dorsally in the upper part of medulla, and these fibers emerge from the dorsal median sulcus in the floor of the fourth ventricle. Further, these fibers run horizontally as the stria medullaris to reach the middle cerebellar peduncle and finally reach the cerebellum. Okay. Next are the openings in the fourth ventricle. This is also important opening. There are 5 openings or communications in the fourth ventricle through which the CSF flows. Okay, and communication with third ventricle via cerebral aqueduct, communication with central canal of medulla oblongata, 3 foramens, foramen of Magendie, single foramen, and 2 foramen of Lasca. Foramen of Magendie is large opening in the midline in the lower part of inferior medullary velum. And through the foramen of Magendie, fourth ventricle communicates with the subarachnoid space. Next is 2 foramen of Lasca. These are 2 lateral openings, one on each side, and they lie at the ends of lateral recesses and communicate the fourth ventricle with the subarachnoid space. At the foramen of Magendie and foramen of Lasca, the ependyma is continuous with the pia mater. Okay, so these are the communication. Communications can be given as separate questions. Okay. Next are the recesses of the fourth ventricle. See, this is the schematic diagram of fourth ventricle. On the 2 sides, these are the lateral recesses where the foramen Lasca is present. Here is the dorsomedian recess. These are the dorsolateral recess. Dorsomedian recess is extending into this cerebellum. Here is the dorsomedian recess is present. Okay. So there are 5 recesses or pouching of the cavity of fourth ventricle as follows: 2 lateral recesses, 2 dorsolateral recesses, 1 median dorsal recess. So we'll discuss the recess in details. Lateral recess, each lateral recess extends laterally between the inferior cerebellar peduncle anteriorly and the flocculus posteriorly. Laterally, this recess communicates with the subarachnoid space through foramen of Lasca. Dorsolateral or lateral dorsal recess, each lateral dorsal recess passes backward on each side of the median dorsal recess above the inferior medullary velum. This is location of dorsolateral recess. Next is dorsomedian recess or median dorsal recess. It lies in the midline, extends into the white core of the cerebellum in between the nodule and lingula. Tela choroidea of fourth ventricle. It is double-layered fold of pia mater which contains the blood vessels and enters the fourth ventricle through the interval between the cerebellum and the lower part of the roof of the ventricle. Next is choroid plexus of fourth ventricle. Sometimes it is asked as a part of the long question. Choroid plexus of all the ventricles. Discuss it. Okay. You have to discuss where it enters, what are the blood vessels lying within this choroid plexus, all the choroid plexus of lateral ventricle, choroid plexus of third ventricle, choroid plexus of fourth ventricle. Like this, all the points you have to write. So, choroid plexus of fourth ventricle is a capillary plexus of blood vessels between the 2 layers of tela choroidea, and the choroid plexus of fourth ventricle is T-shaped. Vertical limb of the T is double. Horizontal limb of the plexus extends into the lateral recess, even protrude out through the foramen of Lasca into the subarachnoid space. Choroid plexuses are supplied by choroidal artery, that is branch of posterior cerebellar artery. Okay. And CSF is produced by choroid plexuses of the brain. Now, clinical aspect. Hydrocephalus is a condition that occurs due to abnormal increase in the CSF within the ventricle system. Okay. It may occur due to occlusion of outflowing channels of the CSF. How the CSF flows? From the ventricle, it goes to subarachnoid space. From there, it is drained into the dural venous sinuses. Okay. Via the arachnoid granulation, it is absorbed into the dural venous sinuses. Sometimes the foramen of Magendie or foramen of Laska may get occluded due to growing tumors or fibrous adhesions after meningitis. It may produce hydrocephalus. Next is medulloblastoma. It is most common tumor in the region of fourth ventricle. Arises from poorly differentiated primitive neuroectodermal cells of cerebellar vermis. Now the vital centers, they are located deep to the vagal triangle in the floor of the fourth ventricle, and any injury to this area may be fatal because there will be stoppage of respiration and death can occur. Okay, and also the heart can stop, circulation can stop, and death may occur. So vital centers are located in the medulla mainly, in the floor of the fourth ventricle. This tent-like cavity is the fourth ventricular cavity. See the three parts of the brainstem. Here is the midbrain, here is pons, here is the medulla. So fourth ventricle is lying posterior to the lower part of pons and upper part of the medulla. And this is cerebellum. So the fourth ventricle lies anterior to the cerebellum. Okay. Now the its communication, you see, this is aqueduct of Sylvius. Via the aqueduct, it is connected with the third ventricle. Here is the position of third ventricle in between the two thalami, and below this fourth ventricle is connected to the central canal of the medulla oblongata. See in this section, cerebral aqueduct is very much prominent. Here is it continuous with the central canal of the medulla oblongata. Okay. Next, you see it has a roof. This part is forming the roof, and this recess is known as median dorsal recess. Okay. So roof is formed by superior medullary velum. This thin membrane-like structure, curtain-like structure, this is known as superior medullary velum, and inferiorly here is the inferior medullary velum. Okay, these two are forming the roof of the ventricle, and here in the lower part of inferior medullary velum, here is a opening in the midline that is known as foramen of Magendie. On the two sides, two opening is present, that is known as foramen of Laska. Through these foramens, the fourth ventricular cavity is connected with cerebellomedullary cistern. Cerebellomedullary cistern is dilatation of subarachnoid space containing CSF lying between the medulla in front and behind the cerebellum. Okay, so posterior to the medulla, in this position, the location of cerebellomedullary cistern. After that, CSF passes to the subarachnoid space, and in the subarachnoid granulation, it is absorbed into the dural venous sinuses. Okay, and this is the choroid plexus of the fourth ventricle extending into the fourth ventricle from the lower part of the fourth ventricle. And you can see the floor here this part is the floor. Half of the floor you can see here, because half of the brain has been removed. Okay, so this midline structure, this is, here lies the median sulcus. Okay, parallel to it, this sulcus is the sulcus limitans. Okay, in between the median sulcus and sulcus limitans, the elevated portion is known as the median eminence. Okay, এই যে এটা ওখান থেকে দেখতে পাচ্ছিস, here is the sulcus limitans. Okay, so in between the median sulcus limitans lies the median eminence. In the upper part of the medial eminence, in this region, and just above the middle of the medial eminence, here is the location of the facial colliculus. Okay, and sulcus limitans, in the upper part, it will form the superior fovea, and here one bluish gray structure is present, that is known as locus ceruleus. Iron content is higher here, that's why the bluish gray discoloration is present. And in the lower part, you will see the vagal triangle and hypoglossal triangle, and lowermost part you will see the obex and the area postrema. These parts cannot be seen. If you cut the specimen and separate this brainstem part, then you will see the whole of the floor. And
in the, if whole of the floor is present, then you can consider the obex and the area posterior. Okay, understood? So here this part is floor, this part is forming the roof, and only dorsomedian recess you can see here. On the two lateral side is the lateral recess through where the foramen of Lasca is present, and just lateral to this median recess will be the dorsomedian recess. So 5 recesses, and the communication with the third ventricle, with the central canal of the medulla oblongata, with the subarachnoid space via 3 foramens. Okay, so 5 openings, 5 connections. Okay, understood? Okay, so that's all. And location is important. It is lying posterior to lower half of pons and posterior to upper half of the medulla and anterior to the cerebellum. So this tent-like structure is the foramen, fourth ventricle, connected via aqueduct of Sylvius with the third ventricle, and connected with the central canal of the medulla oblongata below, and also connected to the subarachnoid space via foramen of Magendie, single foramen lying in the midline, and paired foramen of Lasca lying on each side. Okay, understood?